Let's have a few minutes. Let's see here. I'm going to share my s- screen with all of you. Let me see here. Hmm. Hold on to where we're at. Here we go. My doc slideshow. Okay. So can you guys see my screen?
Not yet.
Okay. All right. You guys my screen now.
No.
Mm-mm.
All right. Let me see. Share. Here we go. Desktop. Zoom may not be able to record the contents of your screen. Quit and reopen later. All right, let's see if I can share now. Okay, I think that's it's gonna work. Allow. And you guys can see my screen now?
Yes.
Okay. And how about now? Do you guys see me on the screen? Okay, so today we're going to talk about, well, first of all, for those who don't know me, my name is James Antezana. I'm a vascular surgeon at South Charlotte General and Vascular Surgery. I am the division chief and also the director of our cath lab. And what I do is primarily limb salvage. And although as a vascular surgeon, the scope of my practice involves everything that's vascular, I primarily focus on something called limb salvage. In Spanish, it's known as salvamiento de miembro inferior. So with that being said, I'm going to continue to talk to you guys about diagnosis and management of peripheral artery disease and what is limb salvage. Okay. So before we dive into this, we have to be very clear and understand that this pathology, this condition, creates a detrimental effect on the human body. And it's associated to multiple factors that can contribute its progression. And in the epidemiology, it's important to understand that worldwide, more than 230 million people are affected, according to Lancet 2024 global. So this is a significant problem. It's an epidemic. It's everywhere in the world, and primarily in developed nations. So in the United States alone, between 8 to 12 million are affected with this condition, according to the American Heart Association data provided in 2023. The diabetic population who is tremendously affected by this condition is 1 in 3 patients. Greater than the age of 50 will have PAD. The prognosis for PAD, well, PAD goes hand in hand with coronary artery disease, and it has an equivalent about 30% 5-year risk of myocardial infarction, stroke, and vascular death. I hope everybody speaks English. If you guys want me to do this in Spanish, I'll be happy to. Everybody okay and comfortable with English? Si no están cómodos, yo puedo darles en español también, pero yo sé que muchos de ustedes aspiran a ir a un país donde, pues, a desenvolverse, o estoy equivocado. A ver, ahí vamos a preguntarle a Jonathan Batista, que estaba sonriendo todo. Pues no sé si entiendo o piensa que está ahí Mickey Mouse hablando por la tele. No te escucho, Jonathan, estás con mute. ¿No? ¿Qué pasó con Celso, que estaba por ahí? Nada. Ok. ¿Qué les gustaría? ¿Hablo la charla en inglés o lo español?
In English, doctor.
Okay, very good. So let's continue. All right. So one of the most interesting things about this condition, it is underdiagnosed. So greater than 50% of symptomatic or atypical symptoms will go unperceived with this diagnosis, which is pretty bad because what happens when you miss the diagnosis is with illness, eventually blocking off their arteries and losing substantial amount of blood flow to the lower extremities, which causes them to have claudication, which is one of the symptoms, and then the last sign, which is the loss of tissue, ulceration, etc. All right, so clinical presentation. You've got individuals, of course, that are asymptomatic, and then you have individuals that have intermittent claudication. And then the final end of this disease is critical limb-threatening ischemia. This is where us vascular surgeons are scrambling to pick up the pieces to be able to help these patients. Yarina, ¿estás entendiendo? Yes? Okay, very good. All right. So the symptoms are often masked by other conditions. Okay. So you can have neuropathy, you can have arthritis or spinal stenosis that can mimic claudication. And so you have to be a very good clinician. And coming from Latin America, we have a lot of pride in how we approach our patients. And we understand that 80% of our clinical exam findings will determine our diagnosis. Everybody agrees with that? You can nod your head. And the reason that 80%, we're good clinicians, we know how to use our eyes, our sense of smell, our sense of touch, and and 20% confirms our diagnosis. So symptoms often masked by neuropathy, arthritis, or spinal stenosis called the Lariche syndrome. This is the terror of all males, but a claudication, impotence, and decreased femoral pulses. The most important one for males is impotence, right? No one wants to have impotence. But a claudication goes along with impotence when the disease is located at the bifurcation of the aorta, when it affects the common iliac arteries, which in turn affect the internal iliac arteries, and then to those vital organs that give the impotence, a vascular type impotence. When you check femoral pulses in your patient, you'll have a decreased pulse. And then finally, we have something called rest pain. Rest pain is not the woman in penitence at the church that's kneeling in pain. It's the patient that when sleeping at night, all of a sudden has pain in their leg and numbness, and they have the urge to get up or hang their legs off the bed. This is a very, very classic description of patients with critical limb-threatening ischemia. RC4, Rutherford category 4, starts with rest pain. Distal burning pain at night relieved by dependency. Okay, very important. So what are the risk factors? We got risk factors that are non-modifiable, and we have risk factors that are modifiable. Patients over the age of 65, of course, you can't change that, but that puts you at a higher risk to develop PAD. The male sex, family history of atherosclerosis, look at their mother, their father, their grandfather, their great-grandfather, whatever. If you understand family history, you're going to understand what their genetic predisposition to developing this type of disease. Genetics, ApoE, LPA, these things we cannot change. These things are our own biomarkers that we carry, okay? What is modifiable is what we need to tackle, and that is smoking cessation, diabetic control, management of hypertension and hyperlipidemia, and prevention of chronic kidney disease, mitigation of obesity, and a sedentary lifestyle. So these are the risk modifications that we can tackle to help our patients mitigate their disease. We're not going to eliminate the disease completely in many instances. We can just slow it down. But I think with the advent of the new technology in terms of diagnosis, risk factor modification, we can actually make an impact in these individuals. So their disease may not even succumb to a full-blown picture.